we go. Y'all see the slides? Okay. So I thought we'd take a couple minutes at the start of today to talk about a structured way to really pull families in and loved ones and family systems into the work that you're already doing in CBT and otherwise. So learning objectives, just talk about the rationale about why we're engaging loved ones. You all, I think we've talked about that at length before, but just touch on that as a reminder, and then providing an overview of what this REORDER model is. And REORDER, by the way, stands for Recovery-Oriented Decisions for Relative Support. So currently, family services are pretty minimal, and it seems that's because there are a number of roadblocks that get in the way of engaging loved ones: access to programming, availability of programming, interest and engagement, what agencies are able to offer, and so on. And research has consistently found that even minimal contact occurs between a clinician and family members in less than half of the cases of those who are diagnosed with schizophrenia. So more than half of the time, no contact occurs. Less than half of the time, it's minimal contact at best. Much. So, there's room for improvement here. These are things that we can be working on, thinking about, and incorporating into our practice, because we know that it works. When you have family systems who are knowledgeable and who are appropriately supportive, outcomes are improved for everybody. We see not only, symptoms are better managed, fewer hospitalizations, but also, people are back to work. They are engaging in social activities. They're feeling better about themselves. They are working better together as a family unit. Family members are feeling less burdened. All of these great outcomes. And so we know it's available and we know it works. It's just something that, I think it can sometimes be difficult to do in actual practice because of billing and time and all of those other barriers that get in the way. But engagement early on, when you're starting to work with an individual, or as you're developing that rapport and you're getting to know them and you've built that trust to where it might be a good place to really involve family members or loved ones, that's really our window of opportunity. So it's really important that we are consistently checking in with the individual and with loved ones and adjusting how involved or engaged fits for that family system at that particular time, because it does look different at different times. If somebody is having a difficult time going through a stressful event, experiencing more symptoms, that might be a time when family steps in or loved ones step in a bit more. And then, helping loved ones to feel more confident and comfortable stepping out when the individual is starting to feel better. So our jobs really are much easier when we have those supportive and knowledgeable loved ones engaged, and when this is a part of sort of our standard operating procedure. But what happens when there is this ambivalence or a hesitation to involve loved ones, either on the part of the individual or on the part of the loved one to engage? How do we overcome some of those barriers? And so this is really where REORDER can be extremely helpful. We know that, there was a massive meta-analysis done back in 1994 and has been updated time and time again. And we know that longer-term family interventions, structured interventions, evidence-based interventions can be extremely helpful. That's where that research comes from. But even if you have a family or system involved in at least 4 sessions in less than a 6-month period of time, you still see positive gains, maybe not as robust as a full family psychoeducation 2-year program. But this is where REORDER can kind of bridge to those services. So REORDER is a brief intervention. It's structured. It has a little manual that comes along with it. And I really love the structure because it actually gives scripted language for you to use. Things about how to talk with the individual, how they can talk with their loved ones. It's very, very nicely structured. But it promotes recovery. It encourages consideration of involving loved ones in treatment. So it's not a guarantee of involvement, but I think it's important that we're having the conversations. So what might it be like to involve this loved one? What are your hesitations? What are the positive things that could come from it, so that the individual can really weigh the risks and benefits of involving a particular loved one or multiple loved ones? It can be a precursor or lead into that longer term family psychoeducation, the evidence-based practice that the schizophrenia port that I just mentioned on the previous slide recommends. And the importance of defining loved ones very broadly, very inclusively, a very open definition. The primary aims of REORDER are to provide a recovery-oriented approach that optimizes loved ones' involvement in treatment. And so that doesn't necessarily mean coming to all of your sessions, but it's figuring out with the individual and with that family system what works best for them and what their level of need is at this particular time and how that looks different over time. It promotes recovery through client-centered shared decision-making. And it increases the likelihood that loved ones will participate constructively, being the operative word, in an individual's treatment and recovery. Why it works, what makes it so that we can implement this kind of short-term intervention into our regular ongoing services or practice is that it's user-friendly for providers. Like I mentioned, it's nicely scripted, it's well laid out, and it's very structured, but it is also flexible. It uses some rehearsals with the individual so they can get some practice, those sample scripts, talks about the importance of goals and of fitting the goals of the family system into the work that you are doing with the client. And also provides some agendas to help you map out sessions. It is client driven. It involves shared decision making. It has this gentle, unassuming approach because it is very much client driven. It allows them the floor to make the decision, but it helps them weigh the pros and cons with you and think through that. And it's very manageable and it's palatable because it is such a short-term intervention. Families may be involved for only 3 or 4 sessions. And that's completely okay. That's the expectation. If it turns into something more, blossoms into something more, even better. It is a 2-phase structure. So there are individual interventions for about 3 sessions, and then the family or loved one piece for 3 sessions. The second and third session in this sort of phase 2 may include the client, but does not necessarily have to. It's just up to 6 sessions max, and it takes about 45 to 60 minutes per session, and it is across a 2-month period of time. So something that, ideally would fit well into your current practice, just, having these sessions every other session or every 3rd session with the work so that you can continue on the work that you're already doing with that individual. What you would need if you decide to use this approach is the guide or the manual, which, when you get this PowerPoint, that'll be sent along with it. Training in the REORDER model or familiarity with the REORDER model, really getting to know what the expectations are, what the format is, how the manual is structured. A real interest in involving loved ones is obviously key. And also some knowledge about the barriers or facilitators that we've talked about previously in treatment so that we know what to expect when we're introducing the idea to the individual or to the family members about getting involved. So the phases, they're, the 3 sessions for the individual. So in this phase 1, the provider and the individual are really engaging in a collaborative discussion about recovery goals, and then helping them think through who, one of their loved ones could help them reach those goals and in what ways. So what would the ask be? What might that look like? Talking with them and normalizing, very importantly, about hesitations that they might have about involving those loved ones into these goals, and also talking about the positive and negative potential outcomes. And really, this could be something that's done outside of the REORDER approach. It could also be done with a family who you might be working with, talking with on an ongoing basis, but this is something else to be considering in your work just on an ongoing basis. We as providers really work to empower the individual to invite their loved ones to join us in these sessions. And then we work with them to develop skills to advocate for their loved ones' involvement with other mental health providers. So you want them to come, what might be the benefits of them coming to a medication appointment? What might be something that makes you a little nervous about that? How do you talk with the psychiatrist about what it might be like to invite them? Is the psychiatrist open to that? How do you advocate for that? So it really puts the client in the driver's seat and empowers them about what they want their treatment to look like and who they want involved. So this just gives you a little idea about some of the structure within the manual that you'll see, but it assists with the first step is figuring out the who. It's always figuring out the who. So who might be the loved one or loved ones that you would like to participate with you? And what does that relationship look like? How has that changed over time? What's the current status? And so it gives you some really nice sample scripts for how to engage in those conversations. Some techniques that are recommended and often used in phase one will be very familiar to all of you, especially with the CBT training, but building that alliance and rapport, using a decisional balance, or personal decision guide. If you all are familiar with the Ottawa guides, they have lots of them. If you are interested, I can get you that information too. I don't know how often you use the personal decision guide, but it's pros, cons of making decision A and pros and cons of not making decision A. And what that looks like and how you can involve other people in your decision making. Values clarification, or the values card sort, is an excellent one to use in this phase. Problem solving, behavioral rehearsal. And again, these are techniques that you can use with an individual who already has ongoing family engagement, so not a family you're currently trying to pull in on a routine basis. So outside of reorder, these are things that can be useful. So just to save some time, it goes into some of the details of what each of these 3 sessions within phase one looks like, but I'll leave that in the PowerPoint, but it's the summary of what's in the manual. But to save time, I'm going to skip those today. And then phase 2 is engaging that loved one and working with the loved one. And there's an opportunity in the second and third sessions of phase 2 for the client, the individual, to become involved. So if a loved one accepts the individual's invitation to participate in your work, the focus is really on engagement and getting to know that loved one, their relationship with the individual, their experiences, their perspectives. They get some very basic psychoeducation information and tools that help them to work with the team in a collaborative fashion. How do you prepare, for example, for an upcoming medication appointment is a big one. How do you participate effectively in those appointments? And also referrals to support groups or other informational groups like NAMI, National Alliance on Mental Illness. The individual's involvement is optional, and it depends on the extent to which the individual wants to be involved, and if the loved ones also would like a little space to have a couple sessions of their own. So the alternatives are dependent upon the loved one's engagement or the dynamics. So you can use an MI kind of an approach for those who are ambivalent to kind of help them figure out where they want to fall on their level of involvement, or for more knowledgeable families, those who maybe had engaged for a longer period of time, you can move on to more advanced education. And then make recommendations for a longer term family psychoeducation kind of a service when they're ready for that. So again, here's a sample script from phase 2, how you would have your initial session with the loved one. Again, the individual would not be present for this one, so it gives them some space to share their experiences and perspectives. Sample techniques, again, you'll be familiar. So alliance building, talking about how critically important communication is between the individual, the family system, and the treatment team, and how we can help facilitate some of that work. The importance of a shared definition of recovery and understanding everybody's perspective on what recovery means. That importance of discussing expectations, belief systems, value systems, really understanding the loved one's perspective on all of these things so that we are ensuring that our recommendations don't work against us. Because, if we're making recommendations that aren't in line with what the family's belief system is, then we're really undermining the work that we're trying to do. And we are oftentimes pushing family systems away without even knowing it. The importance of using summaries or restatements so that everybody's hearing the same information in very neutral terms. If there's some kind of tension between two individuals, then something one person says is always heard through a negative filter by the other person. So if you're able to restate or summarize what you've heard, it's heard through more neutral ears. And then obviously providing education referrals, things like NAMI, other groups that your agency may have available. Again, here are the sort of summary details for each of those 3 sessions in phase 2. And just to share a couple of early outcomes with reorders. So this was originally designed for the VA system. And they looked at, 226 veterans compared with the treatment as usual group. And we saw that, paranoid ideation was decreased, feeling that they were being able to get out of that feeling of being stuck, as a measure of recovery. But then also the finding was that there was a robust impact on family involvement. So 52% of families, family involvement from reorder versus 13% for those who had treatment as usual. And it was actually an enhanced version of treatment as usual. So they actually even had a little bit of a leg up, and you can see the difference about how engaged families were when we offered them the structured approach where the client was the one inviting them to the sessions. And so very promising data, very, for such a simple intervention that provides so much structure, pretty low hanging fruit, pretty small ask, it can still make, a big impact on just getting the family involved, getting to know them, starting to have those conversations so that they know that they're welcome. So the guide will be sent to you following, along with this PowerPoint. And so just start thinking about how you might incorporate reorder model or something similar to this, into your existing services, so that it's not a huge ask. It doesn't pull away time from the individual, consistently or too much if you're working on something very concentrated, but that you can still incorporate the family so that they're aware of what's going on in session and they know how to be supportive of that when the individual is at home. So